Welcome everyone to this afternoon's webinar session on collaborative management of antipsychotics in people with dementia. I'm Chinese Venso, consultant old age psychiatrist working in Anairin University Health Board, and we'll be presenting with Dr. Tessa Lewis, who's a GP working in Anairin University Health Board. She has kindly stepped in to cover for Dr. Shubha Singhal, our GP colleague who is unable to join us today. Also presenting is Elizabeth Bond, who is a mental health consultant pharmacist working at Betsy Carl Wilder University Health Board. Given the time constraints, we will be concentrating on people who live in care homes, but welcome discussions around other care settings as part of the question and answer session. We know that there are risks of stroke and sudden death associated with the use of antipsychotics, and so we must be very cautious about using them and ensuring a robust assessment and review process to justify their use. As you can see in the slide presented, the risks are an additional 10 deaths, an additional 18 cardiovascular adverse events, and an additional 58 to 94 patients with gait disturbance in every 1,000 who have antipsychotics with dementia. Evidence also suggests that longer-term treatment may result in additional 167 per 1,000 deaths over a 2-year treatment period. During this session, we want to raise awareness of the all-Wales antipsychotic prescribing protocol and encourage people to work together to ensure people living with dementia are not left on antipsychotics unnecessarily. We would like to demonstrate how the tools provided will encourage good documentation and highlight how joint working can provide best care for our patients. We will follow our patient John, who lives with dementia in a care home, to demonstrate how the protocol can support his management of distressed behaviors. John is a 77-year-old male. He was diagnosed with Alzheimer's dementia about 4 years ago and has been living in a care home for the last 6 months. At the home, John became aggressive and frequently lashed out at members of staff without warning. Carers were not able to distract him despite attempts to go through his memory book or off-activities John would usually enjoy. Despite these person-centered assessments being put in place, John continued to lash out at staff as they tried to de-escalate him, and on one occasion, he threatened to punch a resident. The care home staff completed the ABC, but could not find a trigger and put some person-centered interventions based on the "This Is Me" document in place. The ABC tool for dementia, for those of you who may not be familiar with it, stands for Antecedent, Behavior and Consequences Tool. It's a clinical assessment tool that captures events prior to the behavior as well as the consequences. Well, the care home staff were unsure whether John had any pain or infection, although he denied pain. He also had no temperature, so they called the GP for further advice. I'd like to invite Dr. Lewis now to tell us what the GP did next.
Thank you. I think it's helpful to see that ABC form to get a better understanding of the behaviour that's causing concern. If I'm asked to see somebody or check someone over who's got delirium, confusion or behaviour that challenges, I often find the PINCH ME acronym helpful. That stands for pain, infection, nutrition, constipation and hydration. And then the ME stands for medicines and environment, so whether that's changes in the physical or social environment. And just to say a bit more about the medicines, useful to check whether there's been a new medicine recently introduced or a dose that's changed, and think whether or not that could have a side effect that's exacerbated or triggered the behaviour. We know that medicines such as codeine, or if there's a high cholinergic burden, so if the anticholinergic score is more than 3, that can cause confusion. And personally, I find it helpful to look at that repeat list of medicines and right-click on the side effects, just see whether there's potential side effect that can be contributing. And obviously also important is to think about depression and anxiety and sensory deprivation. So once we've tried to optimise all these things and the care home has done all their bits, so that might take a couple of visits. If the problems are still persisting, I think then it's time to ask for the older people's mental health team to contribute.
So thank you, Dr. Lewis. So then John was visited by an older people's mental health nurse who conducted a thorough assessment to explore the possible reasons for John's distress and reviewed that clinical and environmental causes for the distress had been addressed. As part of the assessment, the nurse utilized the Cohen-Mansfield Agitation Inventory to gauge the frequency and severity of John's agitated behavior. You can see this inventory on the side of your screen. The findings were then shared with an old age mental health psychiatrist who determined that John was severely distressed and at risk of harm to himself and others, warranting the recommendation of an antipsychotic medication. Due to John's lack of capacity to comprehend his care and treatment needs, a discussion was arranged with his wife, Jane, to explain the rationale behind the recommendation and the associated benefits, risks, and monitoring arrangements. It was explained to Jane that starting antipsychotic medication at a low dose and titrating and increasing the dose slowly would mitigate the risk of sudden death and stroke, which was associated with this medication. Subsequently, John was started on the lowest effective dose of antipsychotic medication with plans for a follow-up review within a week of commencement. The baseline monitoring was completed and the antipsychotic was prescribed on the All Wales antipsychotic monitoring record. This slide shows an example of the antipsychotic monitoring record for the initiation part. I'll now welcome Liz to continue the discussion.
Thank you, Shanaz. As you can see from this table, there are several antipsychotics that may be used for managing non-cognitive symptoms of dementia. Each has a different side effect profile, and John was prescribed risperidone, which is generally used for first line for people with Alzheimer's dementia, and it's licensed for use up to 6 weeks. Most side effects are dose-related, and John requires continual monitoring while his dose is titrated. Also, if the antipsychotic is switched to an alternative, it's advised to start at the lowest dose of that new antipsychotic to avoid adverse side effects and titrate up slowly again. The risk of adverse events is highest in the first 4 to 6 weeks of treatment. The care home staff were asked to offer John regular fluids and encourage him to mobilise as much as possible. This helps reduce the risk of harm associated with dehydration and reduced mobility. The care home staff were also advised to monitor for side effects that are commonly found, such as sedation, hypersalivation, reduced posture, reduced mobility, becoming more confused, or any changes in continence or constipation, and to report them if there are any significant changes, as John's physical health may rapidly deteriorate if not promptly addressed. Over the next 4 to 6 weeks, John was regularly reviewed jointly with the OPMH team, and the dose titrated up slowly to manage his symptoms. The reviews were documented using this antipsychotic monitoring record and also the Cohen-Mansfield scoring system. John's dose eventually reached 500 micrograms twice a day, and at this dose, the care home staff reported that John had begun to hypersalivate. He was less able to move independently, and his wife Jane also felt that he was a lot more confused. However, his aggressive symptoms had subsided and no other risks were reported. So the team agreed to try a reduction in the risperidone by 250 micrograms and review in a week. The dose was tapered weekly and stopped without any return of John's symptoms of agitation and aggression. His side effects also resolved, and he became the pleasant and mobile man once again. And hand you back now to Shinaz.
Thank you, Liz, and thank you, Dr. Lewis, for taking us through this session. In summary, we'd like to highlight that clear objective measurements also helped clarify rationale for treatment when we use antipsychotics in patients who have dementia. It's important that we remember that robust monitoring ensures the safest practice during treatment. And the All Wales Antipsychotic Monitoring Record will provide a communication tool for use across care settings. We'll welcome some questions at the end of this. Thank you for listening.